Hello, everybody. My name is Lucy Norcliffe-Kaufmann, and it's my pleasure to be able to speak to you today at Defeat MSA Alliance. Here are my disclosures. I'm a full-time employee of Theravance Biopharma US. The opinions here are of my own. So I'm going to start with giving us a research update as to what's new in multiple system atrophy research from the autonomic perspective. I'm going to focus on what we've learned, what we still need to learn, and then tell you how you can help speed up our progress. When it comes to developing new therapies for MSA, we have a treatment, we have a group of patients that we need to find better treatments for. But in order for us to begin on that path to find safe, effective therapies for patients with MSA, we want to be able to make people to feel better and also live longer. But in order for us to be able to amount that summitable task, we need to be prepared. So I'm using this analogy of us climbing a mountain together. And in order for us to be prepared, as if we were going to set out on a mountaineering expedition, we need to bring the right tools with us to be able to make that task achievable. And where we see this happening for multiple system atrophy is with a natural history study, which is an observational study that tracks clinical changes over time. And we can use the information that we develop with those natural history studies to be able to plan for better treatment trials, both for treatments that make us feel better and improve longevity. So on the way into developing new therapies, we will obviously have clinical trials. And as we continue to move forward and advance with clinical trials, we will encounter potential setbacks along the way. But in order for us to overcome those setbacks, we need patients with multiple system atrophy to participate in treatment trials and move along that path with us in order for us to reach the top and find safe, effective therapies. So really this stage of being prepared for clinical treatment trials, whether they're therapies that make you feel better or make you live longer, requires a hefty amount of preparation. So for us to have successful clinical trials for patients with MSA, we need to find participants early on that are willing to enroll in treatment trials. We need to target something that matters to patients, and we need to have safe, effective targeted therapeutic strategies. But we also need to know what to measure and how quickly we can detect signs of improvement. This is why we need our natural history study, because it targets all these areas to give us the information that we need in order to run successful clinical trials. So I'm sure you've heard many times that there are two types of studies that you can participate in as a patient. I want us to quickly go through those so that you know what your options are, what you need to do, and what you can expect as an outcome when you participate in those clinical trials. So clinical trials are divided into two main types, those that are observational and those that are interventional. Observational clinical studies, like the natural history study, are studies that you participate in which you do not receive an experimental drug, but they track your information over time while you're on the best available clinical care. Interventional studies are quite different. In those types of studies, you do receive a drug. And those can be divided into two main types. There are symptomatic treatment trials and disease-modifying treatment trials. Symptomatic treatment trials are where you try a new therapy that hopefully makes you feel better or treats a complication of multiple system atrophy. Whereas disease-modifying therapies are therapies that slow down or arrest the cause of the disease by targeting the root cause, and they may not make you feel better right away, and you could have side effects. In a natural history study and these observational clinical studies, you can take all available drugs, whereas in an interventional clinical trial, you take only one new experimental drug. So what I would like to focus on today are natural history studies, and I'm going to tell you specifically about the natural history study of multiple system atrophy, which is a study that we've had going for almost over a decade. It was part of the Autonomic Disorders Consortium, which was founded by a group of academic medical centers that study autonomic disorders and was focused on multiple system atrophy. The site was this observational natural history study for MSA was run at 9 international sites, and all the information from those sites, which focused their care on patients with multiple system atrophy, was fed into a clinical database that was kept at NYU School of Medicine and was used to answer those pressing questions that help us foster more successful clinical trials. The clinical assessments that patients underwent in the natural history study were designed so that they capture the course of the disease and measure multiple different aspects. They included questionnaires, some which capture quality of life, others which have been directly discovered to capture the clinical features of MSA over time. Patients underwent a clinical examination in which we examined many of their neurological features, including sense of smell, cognition, clinical features of MSA, which we call the red flags. We did the standardized MSA clinical rating scales, which you've heard of, which we abbreviate to the UMSA, the United MSA Rating Scale. We also looked at milestones of disease, such as unintelligible speech or needing to use a wheelchair. And we tracked patients' current treatment interventions at that moment in time. At our main autonomic sites, subjects with MSA underwent detailed autonomic reflex testing that looked at their cardiovascular control. This included measuring how their heart rate fluctuates, doing maneuvers that stimulate an increase in blood pressure, as well as looking at blood pressure in different positions when you're lying down and standing up. And we measured the release of nerves that are very important in blood pressure control, as well as other markers of generalized health, with including a complete blood count and a metabolic panel. And then we reviewed each and every case of multiple system atrophy that entered into the natural history study to check whether or not they met standardized criteria for diagnosis. And we followed all of these patients once we'd seen them, either with annual office visits in which they would return to the clinic and we would remeasure all of these features, or we would, if for patients that were unable to return to the clinic, we would follow them up with a phone call and assess questionnaires and other vital pieces of information that we could obtain over a video call or a telephone call. So we have amassed over the years a large number of MSA patients in our natural history study that have been followed throughout time. So what I want to focus on right now is telling you what results we've seen from the natural history study. So you have some information of how this has been used to inform what we know about the disease and how we can improve our clinical trials. When it comes to the natural history study, one of the most important discoveries is that we've become better at identifying the early stages of multiple system atrophy. What I'm showing you here is a cartoon of advancing age and nerve populations. And you can see that in multiple system atrophy, patients start out with a normal nervous system, but over time, we quickly see signs of nerve degeneration that start really around the age of 53. And they can include things like erectile dysfunction, constipation, needing to urinate frequently at night, falls in blood pressure on standing that result in dizziness and lightheadedness, as well as problems with the bladder control, including retention of urine. And those signs and symptoms on their own don't meet the diagnostic criteria for MSA, but we've identified that these are really the early stages, can be the early stages of disease. So as the MSA begins to progress, we start to see patients develop other neurological features, including REM sleep behavior disorder, where they're acting out dreams. Generally, patients with MSA tend to have an intact sense of smell, which differentiates multiple system atrophy from other similar diseases like Parkinson's disease. And as they continue to lose more and more neurons in the central nervous system, we may see subtle motor signs develop and most often than not, patients with multiple system atrophy tend to have quite normal cognition. But it's not until around the age of 57 that we really reach enough clinical deficits, or we see them in clinic, that allows us to diagnose MSA in a patient that presents at a neurological clinic. So really what I'm showing you here is that we have tracked the early phases of multiple system atrophy in a prospective natural history cohort. And we've been able to identify what we think is a window of opportunity, which is around 3.5 years from when the first symptoms of MSA start to emerge and the full diagnosis of MSA can occur. So really what we have with this window of opportunity is a phase of early autonomic signs as well as early motor signs that give us an opportunity to enhance the treatment of multiple system atrophy by finding patients early on when we have the best chance of preserving neurological function with disease-modifying therapies. So when it comes to finding patients with multiple system atrophy early, it can be a little bit like finding a needle in a haystack, right? Because each one of those features alone doesn't make for the diagnostic certainty of multiple system atrophy, but it leads us to an inkling that this is somebody that we could watch. And if we had a therapy that improves function and saves neurons, that would be our ideal opportunity of a window to intervene. So one of the things we did in the natural history study, putting together a number of different sites, was to find a group of patients that had this particular fall in blood pressure, which we call neurogenic orthostatic hypertension, and wonder how we can differentiate that from regular causes of orthostatic hypertension that occur in the general population that don't have nerve damage. So we looked at 402 patients that had a fall in blood pressure on standing, and we measured their heart rate. We found around 380 of those patients had a fall in blood pressure that was diagnosed due to a neurological cause, because they had a particular pattern of autonomic responses that showed us that those patients were having falls in blood pressure because they failed to release norepinephrine, which is the main neurotransmitter involved in the caliber of the blood vessels and control of blood pressure when standing. We identified 24 patients that had falls in blood pressure that were due to other reasons. So they had an intact nervous system. And we found out that we could use the rise in heart rate in relationship to the fall in the blood pressure to be able to differentiate with a good certainty that falls in blood pressure had a neurological cause. So really this test that we did helped us identify those patients with neurogenic orthostatic hypotension that can occur in the prodromal phases of multiple system atrophy. And we went one step further recently in a collaboration with the Innsbruck University medical team, in which we also validated that low rise in heart rate in relationship to a fall in blood pressure at the bedside. So now we have a bedside test that identifies falls in blood pressure due to a neurological cause, which brings us closer to being able to pick out patients with multiple system atrophy in that early autonomic phase. We continued on with this study, and we looked at patients that had a fall in blood pressure on standing that had a neurological cause, and we wanted to know which of those patients developed multiple system atrophy. So throughout the natural history study, as I mentioned to you earlier, we were following patients over time to see what clinical features they developed. And what we discovered was if we had around 80 patients with falls in blood pressure due to a neurological cause on standing, and we found that 8% of those patients within 4 years developed multiple system atrophy. So within this group that have falls in blood pressure on standing, not everyone develops MSA, but some people do. So this brings us a little bit closer to finding that needle in a haystack. We also looked at specifically those patients with multiple system atrophy within that cohort that later went on to receive the full diagnosis. So they were sort of what we call prodromal or premotor multiple system atrophy. So the early phases of MSA were very interesting to us, but the question we had was, what features can we use in a patient that presents with autonomic failure and that fall in blood pressure on standing that could indicate the early phases of multiple system atrophy? compared to other diseases like Parkinson's disease or dementia with Lewy bodies, we found that the early phase of multiple system atrophy was most likely to occur when there was an onset of autonomic failure in the early 50s. And the autonomic failure we found in multiple system atrophy patients had what we call a central pattern of nerve loss, in which we had clues that suggest that it was the nerves outside the brain innervating the blood vessels that were mostly spared, whereas those within the central nervous system get destroyed by the accumulation of this rogue protein alpha-synuclein. We also found that the early stages of MSA were more likely to be associated with early and severe bladder involvement, as well as REM sleep behavior disorder, including acting out dreams. And as I mentioned to you earlier, a good differentiator with Parkinson's disease and dementia with Lewy bodies is that our early MSA patients had a preserved sense of smell. So it was really those constellation of features that brings us closer to finding multiple system atrophy in the prodromal early phases. And indeed, there's a recent paper that came out from the movement disorders group, looks at the current consensus criteria for multiple system atrophy and asks us, can we use this information with a hope of diagnosing MSA clinically at an earlier phase? Because what we recognize is that by the time patients reach the sufficient number of neurological features to be diagnosed with multiple system atrophy, they've already lost a significant number of nerves. And of course, we want to save those nerves as early on as we can. So I would like to tell us, to move on to talk about what's new from the natural history study within the last year. So I mentioned that one thing that is very important is for us to target things that matter to patients. One recent paper that has come out is a review of an expert consensus criteria on swallowing disorders, in swallowing deficits in patients with multiple system atrophy. This was part of an expert international working group that outlined important clinical questions and performed a systematic review. Then they met in person, this was pre-pandemic, and they wrote statements on advising how to manage dysphagia in multiple system atrophy. So this paper really put together those experts in multiple system atrophy and looked at swallowing problems. We found within that, what that group found is that swallowing problems are extremely common in patients with multiple system atrophy and affect up to 68% of patients. It provides screening tools so that doctors can look and ask specific questions to patients with MSA, such as, do they choke? Do they have a wet voice? Do pills or food get stuck in the throat? That can help identify dysphagia when it's present. And it provides guidance on how to manage swallowing problems, specifically for patients with MSA, such as modified diet, or in the later stages of disease, a tube to receive nutrients directly into the stomach, known as a PEG tube. So in terms of what you need to do with this information, is that what it really does as an action item, it puts all the information in one place so that you can give it to your doctor, so that your doctor has access to the most comprehensive expert opinion on swallowing difficulties in multiple system atrophy, so that together with your doctor, you can work out what's the appropriate treatment plan for you. The other thing I mentioned that was particularly important for us is to find out ways in which we can provide the tools to check if a disease-modifying therapy, a therapy that preserves function in MSA, is working, and we want to be able to detect that quickly. So another publication that recently came out from using the data of the natural history study was a review of the standardized rating scale for multiple system atrophy, which we abbreviate to the UMSARS. We put together an expert working group, and we used the data available from the natural history study to outline the limitations of the current UMSARS scale and suggest ways in which we can improve this tool to be able to detect whether a disease-modifying therapy is effective or not. The current scale requires around 100 patients to be randomized either to placebo or active agent in a clinical trial. And of course, this creates challenges because multiple system atrophy is a rare disease. So we identified ways in which the scale can be improved. We suggested items that can be removed or added. And this really is an example of how the natural history study is helping to create tools for use in clinical trials. So this paper is to inform you that progress is being made towards better clinical rating scales. Another thing that is very important, of course, is to identify treatable risk factors that improve health and well-being. One of the most complicated issues to treat in patients with multiple system atrophy is the blood pressure issues, because not only does the blood pressure fall when some patients with MSA are upright, but it can also be very high in the position when you're lying flat. This is something known as supine hypertension. And this study that recently came out in Parkinson's disease and related disorders involved a team of neurologists and radiologists that were looking at patients with MSA over time. And they were examining the impact of high blood pressure when you're lying flat in the supine position on health and survival. Looking at brain MRIs in patients with high blood pressure and multiple system atrophy, we saw differences. We saw that renal function, which is a marker of how well the kidneys are filtering, was lower in patients with multiple system atrophy that had higher blood pressure supine. We also saw that high blood pressure may contribute to cardiovascular events like stroke, myocardial infarction, or other events in patients with multiple system atrophy. So this paper informs you that high blood pressure can be a problem in patients with multiple system atrophy and can have consequences. And as an action item, you should discuss with your doctor if you take particular medications that raise blood pressure or you have concerns that your blood pressure is high in the supine position, so you can develop an effective treatment plan. So what I want to move on to tell you now is that we also looked at not only the autonomic features and the neurological features of MSA, but patients' well-being in terms of rates of depression. This study, which also recently came out in the Journal of Clinical Autonomic Research, looked at the impact of depression on symptoms in multiple system atrophy. It involved a team of neurologists, researchers, and psychiatrists and looked at the rates of depression in patients with multiple system atrophy. And it allowed us to learn about the impact of depression on patients and their lives. We found that 69% of patients with multiple system atrophy score in the high range for having depressive symptoms. We learned that depressive symptoms can occur at any time during the disease course, and that the burden of depression can lead to worse symptom rating, regardless of, for example, the fall in blood pressure. For the same fall in blood pressure, patients with depression rate their symptoms of low blood pressure much worse. So this paper informs us that depressive symptoms can be a problem for some patients with MSA. And if that's something that you think is a problem for you, the action item would be to discuss with your doctor so that we can address that, because that's a treatable complication. So I want to tell you now, we did the natural history study, which was an observational clinical study from multiple different sites. And from that, we have a new opportunity for our patients with multiple system atrophy to participate in a new study. Because of course, in order for us to create a pipeline for new drugs to enter the clinic and successfully treat the problems of multiple system atrophy, we need to understand the disease better. We need to understand how we can quickly detect if new therapies are working. So we need sensitive and responsive clinical endpoints such as questionnaires, as well as biomarkers that allow us to establish how the disease of multiple system atrophy is progressing. So in collaboration with at two sites, at NYU Medical Center and also at the Innsbruck University Medical Center, there is an ongoing observational study known as TRACK MSA, which we're hoping to recruit 50 patients with multiple system atrophy to be seen 3 times at baseline, 6 months later, and 12 months later, and to follow those patients in detail under a microscope over time so we can understand those clinical endpoints and biomarkers of disease. So this TRACK MSA study focuses on how to measure progression in patients with multiple system atrophy. And as I mentioned to you earlier, there are 3 time points in which we're interested in capturing symptoms. We're looking at clinical endpoints that reflect how a person in a clinical trial feels, functions, and survives. And the goal of that is to ask, can we develop a better scale for multiple system atrophy? We're looking at biomarkers, which are substances, structures, or processes that can be measured in the body or its products that influence or predict the incidence of an outcome or disease. The biomarkers that are being studied in the TRACK MSA study are MRIs, brain imaging, as well as taking a sample of the cerebral spinal fluid to look at particular patterns of wet biomarkers that might predict the course of the disease. And we're also taking samples of blood to be able to look at markers in blood that can predict progression. And this combination of the imaging, the CSF sampling, and the blood sample allows us to be able to really understand which are the best biomarkers. So the opportunities for patients that participate in the TRACK MSA study include having access to standardized treatments at 2 well-recognized centers that focus on MSA, and for patients to be followed closely to allow us to fill those important knowledge gaps to be able to determine what we need to measure to understand the progression of multiple system atrophy. This is the name of the clinical coordinator, Mr. Jose Martinez at NYU School of Medicine, for anyone who is interested in learning more about the TRACK MSA study. So finally, I want to touch on the topic of the pandemic and multiple system atrophy, which of course has changed all of our lives in one way or another. But for multiple system atrophy patients, the silver lining of the pandemic, we believe, is that we're now better able to reach patients with multiple system atrophy in their own homes. Telemedicine for multiple system atrophy has been developed at key sites that take care of multiple system atrophy patients while they shelter in place during the COVID pandemic. So these sites have learned on their feet. They've developed new tools, including home kits, hybrid visits, and adapted video rating scales in order to be able to maintain contact with patients with MSA and to continue to follow their progress. So this means that evaluations are now available in patients' own homes, both for clinical care, and there's also the potential that research projects that study disease-modifying therapies or even symptomatic treatments can be adapted with evaluations for allowing patients to be studied in their own homes. So in conclusion, I'd like to tell you that the observational study of multiple system atrophy is helping us be ready for clinical trials. TRACK MSA is a new opportunity to answer how accurately we can detect if new therapies are working in a short space of time. And telemedicine has allowed research to progress. But none of this progress would be possible if it wasn't for you participating in research studies, which are both observational and then participating if you meet the clinical criteria and you feel that that's a problem, what the particular symptom or progression of the disease is a problem for you, then we encourage you to learn more about these studies so that you could consider whether or not you have the time to participate, the willingness to participate, and fulfill the entry criteria. So in order for us to make progress, the most important partner in our journey to be able to do this is you. So hopefully I've convinced you that observational and interventional clinical trials are progress is being made, but what we need now is for you to participate in those studies. Thank you very much for your time.